one of the things that has been remarkable since seeing the advent of the incretins coming to market and first being utilized in weight loss and then in type 2 diabetes and even pre-diabetes is then seeing the evolution of the combination or dual therapy of a GLP-1 receptor agonist with a GIP receptor agonist. And this comes in the form of tirzepatide and has been formally studied and approved for the use of treatment in adults who have moderate to severe obstructive sleep apnea and obesity. Now, with that stated, we see that there is completely robust findings from the phase 3 trial in terms of not only weight loss and obstructive sleep apnea parameters, but also had given inclination to there being the secondary cardiometabolic outcomes, demonstrating improvements in blood pressure, in cholesterol, as well as in things like high sensitivity CRP. Now, what we now are seeing is dedicated studies doing propensity score matching, which is basically a statistical design that mimics really a close approximation to a randomized control trial. So basically doing a balancing of all of the parameters that may potentially influence the outcomes in individuals. And what we're seeing when you're evaluating a propensity score matching that included over 40,000 individuals is significant risk reduction, CPAP or no CPAP, male versus woman, and across all other subcategories, including age, in regards to all-cause mortality, the cardiovascular related mortality, as well as adverse events, as well as renal adverse events. This now is giving the first ever dictation of that when we are looking at the use of tirzepatide in individuals living with obstructive sleep apnea, with or without comorbidity, that there is statistically significant benefits that go beyond the obstructive sleep apnea, that go beyond the weight loss, that truly are making an influence in terms of what longevity could potentially look like. When looking at who may benefit from the use of tirzepatide, one of the things that I would say is that we're seeing benefit across all of the groups. Now, one of the things that we want to think about is who are our highest risk population? It is going to be those who are living with obesity, who may be living with existing comorbidity like type 2 diabetes, and who are refusing or unable to utilize other therapeutic strategies like CPAP. And that is exactly what we're seeing. We're seeing that the risk reduction in individuals who are living without the use of CPAP, actually we're seeing a greater degree of improvement or risk reduction compared to those with CPAP, which makes sense because we're already modifying the risk there. And so this becomes really important when you're thinking about how can I benefit an individual. Now, with that stated, just because someone is utilizing a CPAP, what we were seeing is still a modification of risk for adverse cardiovascular events, mortality, and adverse renal or kidney events. This now means that this does become almost like the Swiss Army knife, not to over-glorify the use of this medication, but really to think very thoughtfully of if I am able to onboard someone who's living with obesity and moderate to severe obstructive sleep apnea, they're able to tolerate it, and they're seeing benefit from this medication. The benefit is going to be more than what meets the eye visually in regards to seeing that slimming of the waist. You also are going to see that they may start being able to have improved diabetic control, improved blood pressure control, and overall risk reduction. So really making it that it's not just the singular individual, but really individualizing how can I actually optimize the whole person, not just the specific thing that we're trying to treat, such as obstructive sleep apnea. When looking at what are some of the current guidelines in regards to what should be the approach in treating people who have obstructive sleep apnea and are overweight to obese, it's interesting to see that the guidelines vary by which academy you're looking at. When you're looking at the American Thoracic Society, the guidelines are actually more prescriptive than what the American Academy of Sleep Medicine is giving a suggestion of. The American Academy of Sleep Medicine encourages for there to be weight modification strategies, but don't necessarily give a prescriptive guidance to how to achieve that, as opposed to when we're looking at the American Thoracic Society and we're seeing that in persons who are going to be more mild obesity, overweight to mild obesity, encouraging lifestyle diet modifications as we become more overweight or obese, those suggestions then become escalated, giving the suggestion of utilizing drug modifying agents as well as then considering bariatric surgery. What we're seeing now, based on the data that is becoming more and more prevalent, and even including the pivotal phase 3 study, where there was the evaluation of use of tirzepatide in those who are using CPAP and not using CPAP. We now are seeing this being replicated with this propensity score matching analysis, demonstrating that irrespective of use of CPAP, this is something that can be beneficial. So when thinking about how potentially algorithms can change for the optimization, personalization, and individualized journey, it is really saying, are we treating obstructive sleep apnea all wrong to begin with? Do we need to start thinking about it similar to other diseases where there may be some individuals where monotherapy is the key? But there probably are more individuals where polytherapeutic approaches may be more optimal. So going beyond thinking about CPAP, we do know that there are individuals who are living with dental devices or oral advancement technologies, also utilizing implantable devices. These do not negate the potential that we may see similar benefits for individuals who are living with obstructive sleep apnea and obesity. So really creating the paradigm of that when you're treating an individual, starting with what is all of the morbidity that is currently present, what is the potential risk of the development of these morbidities and even mortality risk, and how can we modify it and make it so that an individual is going to be more successful living. So I do anticipate that we're going to see not only things like tirzepatide, but a whole host of medications that are going to become part of the natural paradigm of how do we approach. Now, one of the things that I want to make sure that people are listening to and not running into a frenzy of going, great, now I need to know how to manage diabetes as well as obstructive sleep apnea. I'm a sleep doc, and that's not necessarily something within my repertoire. The call to action that we have to consider is the same as in other disease states, where this now also prompts the consideration of how do we create transdisciplinary, multi-stakeholder approaches to being able to more optimize and capitalize on the expertise that each of these stakeholders may have. This allows to, number one, de-burden the individual on this journey, but number two, for there to be mutual learning as well as responsibility sharing in optimizing all outcomes for the individual. So if you feel prepared that you are going to venture into prescribing, whether it's a GLP-1 or potentially the use of tirzepatide, which is a dual GLP-1 GIP or GIP receptor agonist, one of the things to always keep in mind is what are the potential risks that may come along with utilization of these medications. First and foremost, the natural mechanism of GLP-1 is to slow gastric emptying. And so if you're experiencing an individual who already has pre-existing gastroparesis, this may not be something that would be recommended because of the fact that you may create a bigger problem than a solution. The second thing to think about is the fact that whenever we're experiencing a slowing of gastric emptying, this now introduces the sense of feeling full for a longer period of time. This may then prompt people to not necessarily drink the same capacity. It also may create symptoms of things like nausea, and even potentially vomiting. And what we did see from clinical trials is seeing that up to a quarter of individuals may be experiencing things like that, despite the fact that less than 5% are typically discontinuing the medication due to this. With this stated, it becomes really relevant to think kind of similar to how I do when I'm talking about my pediatric patients or even my own kids, is being able to say what are measurable goals of how much fluid intake and how to prevent dehydration and what are signs and symptoms of dehydration. The real concern here is thinking about how that potentially can provoke acute kidney injury and even progress chronic kidney disease to something that may be very damaging, like progressing to hemodialysis. Again, recognizing these are also medications that are going to modify your glycemic control, thinking about the risk for hypoglycemia and managing whether or not someone is on other medications that may be lowering their blood glucose. The final piece is when you're dealing with any medication that is slowing gastric emptying, it is important to know that it can have impacts on how other medications are being utilized. And so if another medication has a very tight window of control, think something like warfarin, you want to make sure that that is being measured very regularly and making the adjustments. Most typically, once we get to a steady dose of medication, about 4 weeks afterwards, we generally find that we get to a new normalization. This is also important when you're thinking about reproductive health and things like hormonal contraceptives, where when you're taking oral therapies, that may be reducing the efficacy of that. Introducing one, not only things like breakthrough bleeding, but also the opportunity for pregnancy. And being that we don't fully understand whether or not there's a risk associated with being on these types of medications while being pregnant and any potential teratogenesis, it would be strongly recommended to use a dual contraceptive, such as introduction of a barrier method. So these are just some of the things that do require a lot of thought to make sure that you're having that proactive conversation, but also a further testament as to why you want to think about having that transdisciplinary approach. In terms of long-term considerations, one of the things just to be mindful of is that we do lose lean muscle mass naturally over time. By the age of 60 years old, we're unfortunately losing almost 1% a year. Now, with that stated, when utilizing any of the medications for weight loss, whether it's through bariatric surgery or through the use of medications, there is the risk of not only having fat loss, but also lean muscle loss. So making sure that you are combining the use of any medication with movement, making sure that we're getting the right number of hours of sleep, looking at our nutritional status, and then also keeping moving. These are the keys to really making sure that you're living a well lifestyle, not just a healthy one.